Hello, my name is Dr. Mark Huffman. I'm an associate professor of preventive medicine and medicine at Northwestern's University Feinberg School of Medicine and the principal investigator of the Acute Coronary Syndrome Quality Improvement in Kerala, or Acs Quik, clinical trial. I'm delighted to be here today with my collaborators and friends, Dr. P.P. Mohanan. Dr. Mohanan, could you introduce yourself, please?
I'm Mohanan. I represent the Cardiological Society of India Kerala chapter and working as a head division of cardiology at Westport High-Tech Hospital, Thrissur, Kerala.
Great. And Dr. Prabhakaran?
I'm Dr. Prabhakaran Dorairaj. I'm a Vice President Research and Policy at the Public Health Foundation of India and Executive Director of the Center for Chronic Disease Control in India.
We've been working together over the past 8 years to try and improve heart attack care and outcomes in Kerala. Our previous research has demonstrated substantial variability in the quality of care that's received for heart attack patients in Kerala, as well as their clinical outcomes. So we sought to develop, implement, and evaluate a quality improvement toolkit across 63 hospitals in Kerala from 2014 to 2016. To do this, we used a unique study design called a cluster randomized step wedge design, where all the hospitals actually start out in the usual care or control arm, and all hospitals end up in an intervention period. And the period at which they move is actually randomly selected in a one-way crossover fashion. So the purpose of this helps us understand, did the intervention that's based upon principles of the American Heart Association's Get With the Guidelines program, is it actually effective? Over the study period, we recruited 21,374 participants into the study. The participants were a median age of 60.7 years. About 3/4 were men. 2/3 had ST elevation myocardial infarction, and actually half had diabetes. Our intervention included an audit and feedback reporting mechanism, patient education materials, standardized admission and discharge checklists, and linkage to emergency cardiovascular care and quality improvement training. Our primary outcome was the rate of 30-day major adverse cardiovascular events, and this was defined as all-cause mortality, reinfarction, stroke, and major gusto bleeding. Our results demonstrated that the intervention actually led to an increase in life-saving medicines such as beta blockers, anticoagulants, and even reperfusion, which is opening up of arteries for patients with an ST elevation myocardial infarction. At the time of discharge, the intervention also led to increases in use of medicines such as beta blockers, statins, and ACE inhibitors. Over the study period, we observed a difference between the intervention and control group in the primary outcome. In fact, the intervention group had a lower 30-day major adverse cardiovascular event rate of 5.3% compared with 6.4% in the control or usual care arm at 30 days. Because things are changing rapidly in a place like Kerala, we actually adjusted for things like temporal trends to understand what is the wave of improvement in care, some of the work that Dr. Mohanan and his colleagues have been working on over the past 10 years. When we adjust for those temporal trends, we actually saw an attenuation of the effect of the intervention on clinical outcomes. But this is the first and largest study of its kind in Kerala to demonstrate the effects of a quality improvement intervention. We're really excited about our promising results and look forward to more research. So Dr. Mohanan, maybe you can tell us a little bit about the work that you and others at the Cardiological Society of India Kerala chapter have been doing to improve quality and safety for patients over the past decade.
We started sometime in 2005 along with Professor Prabhakaran, where we showed that if you do some quality improvement program we involved about 35 physicians, we showed that definitely the process of care and the improvement in the medical treatment is possible with very minimal efforts from your side. Later, we collected the largest data on ACS, collecting 25,000 patient data on the ACS care, which sort of showed us that there are gaps in the treatment. We could very well improve those gaps, and that's what we possibly showed from Acs Quik. The lessons that we learned from the ACS registry paved the way for the Acs Quik, and whatever you have discussed is the improvement of the process of care.
So Dr. Mohanan, can you tell me a little bit about what has been changing in the health system within Kerala? I mean, you're a practicing cardiologist. You see patients all the time. How do patients get cared for today in Kerala? What was it like 5, 10 years ago?
But one of the basic differences that we have seen is the reperfusion technology, especially, you should know that India is the capital of coronary artery disease, and we have a sizable amount of ST elevation MI. The reperfusion strategies has significantly changed. If you look at Kerala ACS registry data, the catheter-based reperfusion rate was dismally low, maybe about 12%, less than that.
Right.
But when you have our own data, that showed a significant improvement. That's only one part of it. I mean, it's true that the guideline-based treatment is there. As you have seen, 95% or 96% of DAPT or anticoagulants. But even now, there are scopes for improvement in the other usage medications like beta blocker, ACE inhibitors.
Sure. Dr. Prabhakaran, can you put some of these results into context beyond the state of Kerala throughout other parts of India?
Right, Mark, when we think of quality improvement programs, it is multidimensional. You need to think of in terms of prevention, care of acute illness, and rehabilitation. Or in a second way, when you look at disease itself, like acute myocardial infarction, you need to look at pre-hospital care, in-hospital care, and post-hospital care. The third is the actors, the patients, the providers, the health system, and also the policy. So putting everything into context, we require a multidimensional approach if we have to combat cardiovascular disease in India or anywhere else for that matter. And I think, one, it starts with a high level of activity in terms of prevention, starting from children, moving upwards in terms of managing high-risk chronic disease care like hypertension, diabetes. But coming specifically to this program, I think this program can be scaled up to multiple locations in India, particularly where the care is not as optimal as we have in Kerala. That's number one. Second, I think it can be enriched by adding some bit of digital technology to the care so that some of these things become automated. Now we have machine learning, artificial intelligence, all those can be added so that it becomes a very powerful tool.
Wow, great. Dr. Mohanan, can you talk a little bit about some of the work maybe outside of acute coronary syndrome? I think the Cardiological Society of India Kerala chapter has quite a number of registries in other cardiovascular conditions. Can you talk about that?
We have almost now 7 registries running in Kerala by the Cardiological Society of India. One is in heart failure. We have, and that could be the quality improvement program in heart failure could be definitely an area where we can definitely score. We are also having data on pulmonary artery hypertension, atrial fibrillation, infectious endocarditis.
Wow. What was the genesis of all this? What led to your organization just being real leaders in India on cardiovascular quality and safety?
I will say that the enthusiasm generated from the initial projects, especially the Kerala ACS registry, when we involved 125 hospitals.
Wow.
And when we got published it in a high-impact journal, I think everybody started having a part of it.
So a little success begat a little more success.
Now, every cardiologist in Kerala definitely want to be involved in data collecting, involved in registries. Maybe we could enthuse them involved with quality improvement programs.
Sure. Prabhakar, how do we take some of the lessons learned from the Kerala experience to do just what I think we're all interested? How do we scale this up? Any thoughts?
Scaling up obviously involves involvement with policymakers, and that's the first given.
Sure.
The second is involving the larger cardiological community into this program. Actually, it's a slow process, but getting them enthused and showcasing the success of this whole network and the infrastructure will really help in scaling up the thing. The third is, I think we need to pay attention to pre-hospital care too, which is a very important component, and that can make a big change, apart from, of course, all the quality improvements that we had in our in-hospital care and discharge care. Then the last thing is thinking through a new paradigm of involving families in the care, involving the communities in care, and looking at prevention as a community level or a family level work would actually enhance some of the successes of this.
Well, this has been just a terrific partnership for me personally to get a chance to work with the both of you and all the people who have helped us through this work together. I really do think that we've only just started. I think it's really, really important to be working in India on improving the quality and safety of acute cardiovascular conditions. This is a country with a huge burden of disease, yet huge opportunities and a lot of really enthusiastic people with great ideas that can not only improve the care of their local and regional communities, but beyond the borders of India and even places back in the United States here. So I'd like to thank you both so much for coming today and speaking and coming all the way from India to the American Heart Association scientific sessions. Thank you very much.
Thank you.